EUS-guided liver biopsy using a modified wet heparin suction technique. Authors have no disclosures. The field of endohepatology has been evolving with multiple studies describe the success and safety of EUS-guided liver biopsy in obtaining liver parenchymal tissue. The supporting evidence embracing the use of this technique is convincing. However, variabilities in the technique is still an ongoing field for research. There is no consensus for the type of needle, depth of needle insertion, number of passes and actuations, and suction techniques. The following supplies will be needed to perform this procedure: a 19-gauge F&B Francine tip needle, heparin 1 to 1000, 500 cc of saline, 10 cc and 35 cc syringes, sterile cup, absorbent pad, cotton swabs, and formalin. To optimize the duration of the procedure, we recommend set up a processing table with the supplies needed for sample cleaning and collection. This will include a 40 cc of saline in a sterile cup, 35 cc saline syringe, the stylet from the 19-gauge F&B needle, absorbent pad, cotton swabs, and formalin cup. Next, prepare the F&B needle as follows. Open the 19-gauge F&B needle from the package and remove the stylet. Activate the suction syringe and set it aside. Draw up a syringe of heparin and flush through the needle only until a few drops come out. Leave the syringe attached to preserve the column of heparin within the needle. Advance the echoendoscope to the gastric fundus and aim toward the left hepatic lobe. Interrogate the target tissue acquisition site with the endosonographic view using Doppler to avoid large blood vessels and bile ducts. Confirm 4 cm depth of needle insertion as a safe actuation distance. Then you can secure the needle adjustment lock at 4 cm mark. Detach the heparin syringe from the needle just prior to tissue puncture. Before attaching the negative suction syringe, perform one pass, one actuation of the left hepatic lobe by introducing the needle through the gastric wall with a quick stroke. Attach the activated empty suction syringe to the proximal port of the needle. Apply suction briefly by rotating the stopcock 180 degrees and notice a heparin splash in the suction syringe. This indicates tissue entrance into the needle by displacing the heparin in the needle retrogradely. Finally, confirm the suction syringe stopcock is closed and slowly withdraw the needle under Doppler guidance to ensure lack of flow track. To obtain a sample from the right hepatic lobe, advance the echoendoscope to the duodenal bulb. Carefully interrogate the area and set 5 cm depth of needle insertion as a safe actuation distance. Detach the heparin syringe from the needle just prior to tissue puncture. Then perform a one-pass, one actuation of the right hepatic lobe by introducing the needle through the duodenal wall with a quick stroke. Attach the activated empty suction syringe to the proximal port of the needle and apply the brief rotation of the stopcock to notice the heparin splash. Finally, confirm the suction syringe stopcock is closed and slowly withdraw the needle under Doppler guidance to ensure lack of flow track. Remove the needle from the echoendoscope to allow for tissue acquisition. Use a pre-filled 10 cc normal saline syringe and gently flush the needle to express the specimen into a cup filled with sterile saline. Carefully empty the cup with the specimen over an absorbent pad, and gently flush the core with normal saline to clear the blood clots. Repeat these steps until you clear all the blood clots from both right and left hepatic lobe specimens. Use a cotton swab and carefully move the specimen into a formalin cup for final histopathological evaluation. Our specimens were consistent with the recommendations from the American Association for the Study of Liver Diseases regarding adequate sample for diagnosis and staging of diffuse parenchymal liver disease. This includes a biopsy of at least 2 to 3 cm in length, 16 gauge in caliber, and contains 11 complete portal tracts. Our technique is close to the wet heparin suction technique with some differences. We left the heparin syringe attached to the proximal port of the needle until just prior to the liver puncture. This was done to maintain heparin column in the needle. We detached the heparin syringe, then we performed liver puncture. We attached the suction syringe with brief activation until heparin splash was noticed indicating entry of specimen into the needle. Our technique was also close to the modified one-pass, one-actuation wet suction technique with some differences. We used heparin solution instead of normal saline to flush the needle, and we left the syringe attached to the proximal end until just prior to liver puncture. We use a 19-gauge FMB Francine tip needle rather than 19-gauge FMB fork tip needle. We performed a fast one-pass, one actuation with a preset depth of needle insertion to 4 cm in the left hepatic lobe and 5 cm in the right hepatic lobe. The modifications we applied in our technique can improve the quality of specimen by decreasing tissue fragmentation, increasing quantity of complete portal tracts, and increase aggregate specimen length. However, due to the lack of evidence, further prospective studies will be needed in order to evaluate any advantages of this modified wet heparin suction technique.